Yeah. So Saurav also, maybe he can
You can.
come. Yeah. So we'll take questions now. So if there are any questions. Yeah.
Shubhankar, if you want to prejudge the position of your implant before finally fixing it, do you need to position your C-arm in a particular angle or way? Because sometimes the angle of the C-arm also makes a little bit of difference.
So, sir, like I said, you have to ensure that your pre-incision fluoro has to be there. Position the C-arm in such a way that you're making it similar to the standing AP view of the pelvis. So I get standing AP view pelvis with bilateral hip of all my patients. I look at certain parameters in the X-ray, calculate them very meticulously, those ratios on the C-arm once I get the bilateral hip C-arm image.
Okay. You insisted on tranexamic acid to a lot in this anterior. Why? Was there any particular reason about it or not?
Sir, so basically it's a very well-known fact, very well-published, that wound complications are more with direct anterior. And seromas and hematomas are very well known throughout. Most direct anterior surgeons are unhappy with them. And the red dragon, basically in my initial few cases, I had very big hematomas, which eventually settled over time, but that's what I've not had any infections. But what I want to state is with tranexamic acid, I've seen a rapid decrease in those seromas. Of course, I've been ligating the MCFA if I release the posterior capsule. But then there is ample literature now which has come out in the past 2 years which states that oral tranexamic acid in the perioperative period is decreasing hematoma formation both in knee and hip. So I've been
I think the point is taken. We'll go to the next question.
It's not specific to DA.
Yeah, I think you should use it. So, Shubhankar, and to everybody else also, when you're starting off with DA, is it a good idea to start with, fractured neck femur patients or not? Because that's something people say that it's easier. I found it the other way around, maybe,
So, sir, I had the privilege of assisting.
No, you have been trained. I don't want to ask you because you have had you have been trained at a center where DA was done. But for hip surgeons who have not been trained during the residency, to start with the DA in a fractured neck femur, would you advise?
I would not recommend it. I would recommend get a fairly straightforward avian case, preferably not with a broad pelvis, with valgus necks, with a good working space, and attempt your DA with them. Do not go for osteoporotic.
So the point here is, in fractured neck femur, you have osteoporosis also. So chances of fracture becomes more, especially when you try to deliver it. So, you need to be careful if you are starting with only fractured neck femur. And the anatomy is also not that straightforward in fractured neck femur. The neck is broken. So, you are going in. So I think that is a point. I think straightforward avian cases are the best ones with a slightly valgus neck and the working space.
Straightforward avian, primary OA, female is the
primary
ideal
OA
case
only you get
GA.
if you primary OA only
under GA.
You get if you do international patients. Yeah, only patients.
Very difficult to get in Indian patients.
So other than that, I think avian. Okay, maybe any. So the next question is, since we are talking about the approach itself, Saurabh and Subhash, do you think, is it an extensile approach if you are in a problem?
Well, I had, yes, there are some restrictions into it, but the Belgium group, I actually attended one of the meetings, and the Belgium group have started completely doing the revisions anteriorly.
No, I'm not talking about revisions. I'm just talking if you are, posterior approach, the beauty is it's an extensile approach. So I think this is a criticism for DA also.
Yes,
you cannot, there's
can't extend it.
No. They have modified it, in which they have increased the incision more downwards, and they have gone in between the first and the second perforator of the LCFA. So they have made a window between the LCFA, between the first perforator and the second perforator of the LCFA. They have gone through the vastus intermedius, and they have found a way in which they even do an osteotomy if they have to take the stem out, or if there's an extension of the periprosthetic fracture. They have started doing in that way.
So it's very heartening to hear that. The other thing is, Dr. Rohit, So, you do it with a table. So, I always, one of the biggest advantage of DAA to me was that, your limb length, you could get spot with the table. Do you think it is easy or difficult if you're using a table?
So if you are operating from the anterior approach, you can always have the advantage of the fluoroscopy to see the limb length. So it is one advantage. But with the help of the table also, you can definitely mark it. But you need another assistant who is unscrubbed, so to help you out just to see that how much is the limb length. But with the table also, definitely you can get the limb length.
Shavankar.
Okay.
Sir, the contraption I've designed allows me to get an inferior, basically the brake that we have, it allows me to break the table to 90, place the patient with the traction table, and I can release the leg from the traction table and raise the 90. So that allows me to get the best of both worlds.
Okay. Okay. So,
Mike, please.
yeah. So you said posterior vestibular defect. Yeah, I think, if there is a defect, you should go posteriorly, but DA surgeons are able to do. I know of people who are doing revisions using DA, but I think means it's once you are very, very accomplished in the approach, then only. But if there is something there posterior defect or anything, I think it will be very difficult. Saurabh? Subhash? Saurabh?
Yes, I think that makes complete logic. We have the advantage that we know both posterior and anterior and lateral. So we can choose the approach according to the need of the patient. Actually, all these things look fancy, but at the end, DA has given, in some patients, in most of the patients I've seen, that the DA has removed the initial precautions of a hip replacement, in which you have to put the hip in abduction and external rotation. That has gone. The second thing which I probably, differ a bit by Shubhankar is that I have had, in fact, less bleeding and hematoma and pain in DA as compared to a posterolateral approach. But if there is an obvious defect and if we know how to approach that patient in the proper fashion, I will definitely go for a posterior approach in a posterior wall or posterior column defect.
Okay, I think the question has been answered. So we'll go to the next one. So there is another concern with DA is that, you undersize your stems. I think none of you brought it out. So that is another thing, the chances of undersizing stem, what do you think about it?
There is a definite possibility, and probably one of the most important criticisms of DA is that in long term there is there is more femoral subsidence and loosening and the stem, but I think once they have introduced the collared implants on, that is why they have specifically introduced the collared ones. So the collared implants of which they have introduced in these wedge step stems is that prevents the periprosthetic fracture happening and it prevents the subsidence. So yes, you have caught the nerve. And that is a very valid point, but the company guys know how to circumvent that problem as well.
But I would disagree with
so
that.
now the approach came, now the implant has also been changed.
Yes, that's true. That's true. That's a fact.
And now if you have the literature
why
also.
would you undersize the stem? I just can't believe this, because it's been like in the literature been written a lot that you try to undersize. Why would I undersize a stem?
No, but Subhash, that is there.
That is there, but maybe the older literature and older
No. It is there. When you're starting also, if you're doing it,
No,
I personally also feel that, even with the first stem or second stem itself, you have the stability. You would not like to go ahead unless until you see on a C-arm and then see that, your stem size is normal or not.
That means you're not been sufficiently lateralized.
No, the stem is perfectly fine. It is not in varus or anything. So that is there. So it may be your personal experience, but that is
so initially for the starters,
Yeah.
means you feel like that you may break a femur or what. So at that time you go a little bit on the shorter side. But once you get through it, if you have done so many cases, then you can definitely get that femoral size.
So now it's a very interesting theory which is coming out, that they are saying now you can put the collared stem in slight varus.
Yes.
Yeah.
That is the solution.
I think,
I
think Saurabh, so everything is being made so as to make it acceptable.
Yes.
Yeah, so that is something which is there. Anyhow, I think, a cementless stem can be put in varus, slight varus. We have seen it over the years. It doesn't matter much in slight varus. Other than that putting in stem in slight varus, creates a problem with the offset. So you need to remember that also. So, offset also changes. So you will not have a forgotten hip there. So is it, I saw everybody is doing with the normal stems. Yeah.
There's one I would like to caution. If a person is starting, I have had one persistent, I mean, two of the cases in about 100 cases which I've done is, in which when I, in certain position where the offset was less, when I flex the hip about 100 and 110 degrees, the femoral head tended to sublux a bit away out of the femoral, cup. Obviously, use the cup in which it is already smaller than the posterior acetabular cup which you use. I generally use cup 2 millimeters, maximum 2 millimeters more than the intended femoral head. That's because I want to see the posterior colliculus. But I have, so it's very important to have the options of high offset as well as short neck options when you're doing a DA. That's very important. Because you want to have a good, fairly mobile.
So that's another technical point I want to bring out here is, so in posterior approach, sometimes you struggle to reduce the hip. In direct anterior approach, you should not be struggling to reduce the hip. Your reduction should be very smooth. If you are struggling to reduce the hip, that means your neck cut is, or you have to go more deep. Would you like to elaborate on that? Because,
Yes, I agree, because it's very difficult. If you are, again, and there are one more point which I want to add. Now I have stopped, I do a capsulectomy. So I have stopped removing the entire medial capsule. Because if your entire remove the medial capsule, sometimes your femoral head rise stays beneath the rectus, but it doesn't come down. So now I have used the medial capsule as a flap. So it basically guides the femoral head down. I agree what you have said, that if you are struggling in direct anterior approach, it's more difficult to dislocate and relocate already a hip inside.
Yes.
So it's easier to reduce it and difficult to remove it. But if you are having difficulty in reducing it, there is something wrong. You have kept the neck too high, or you have not done the releases enough.
So the reduction should be very, very, very easy, just with the thumb. So another, philosophical point now, since we are close. So you're releasing the strongest ligament in the body is the iliofemoral ligament, and you're taking it out and not repairing it. So do you have any concerns with that? Means in long-term stability?
Means after the release also, if you see, the hip is fairly stable. So I have not found in any of the cases there is some anterior instability until and unless you have increased the anteversion move. So it is one thing which you have to be aware of.
It's part of the capsule only. So you have to release the capsule. The actual capsule reinforcements, they are not ligaments.
So as I could gather from everybody's talk, yes, Shubhankar, sure.
So in my last 50 or so cases, what I felt is that a complete iliofemoral release might not be required. Just the diagonal release is usually enough. If you want to recess the superior capsule, which is also a part of the iliofemoral ligament, then it's up to you. But just that diagonal release, I doubt will give that much instability.
Okay.
I think the most important stability, Vijay, the most important thing which I have realized is that you have not trespassing the posterior capsule. If you are not trespassing the posterior capsule and obturator externus, you are safe.
Yeah, any questions? Yeah, sure. Yeah, so there is a very, very important question. Whether you should buy a fracture table or not, you can do it on a normal table. Which is better? Means a normal table or using on a modified DA table or a DA table?
So means I was initially trained with the DA table itself. So once I came back, I just got it custom made. And it is not that costly what we are getting.
Okay, what about other people? I think Shubhankar, we started with a normal table only.
Yes, sir. So I was trained at AIIMS with a normal table. I did approx 10 or 12 cases on a normal table. Then I figured out that most of us orthopedic surgeons have the traditional fracture table, which can be modified very easily. And I modified it, and I found that the number of releases I had to do were very less compared to a traditional table. So both are fine, just that you have to be very sure of your releases.
Subhash?
So I would say like a table has two problems. One is that when you give the traction to push the femur down, and then you want to see the acetabulum, then sometimes the push on the backside is going to create a problem for them, because that's where they use the most. And to deliver the femur anteriorly, and when you try to relocate the hip, and then the shuck, etc., all those things, they tend to remove the foot from the table, fracture table, and then check, and that's it. Sterility issues are there. So I personally feel that a table is not required, frankly, because
Saurabh?
that shuck test and that feel, all that has gone actually.
I actually, hardly hyperextend my
So
table. So I don't know. I have never done in table, so I would not be able to comment
Yeah.
on a table
So
thing.
I also do it on a normal table, but I think people who do it on a fracture table, of course, fracture table has its own advantage. I think the biggest advantage is you require less amount of assistance. You can even
Definitely
do it with a
assistance is
single
less.
assistant.
You can do more of hyperextension
More
if you
of
want.
hyperextension,
And you can
so-
do more of adduction also. If you
Yeah, it
require.
has
So
its
that
own
also helps.
advantages, but for me, I think using a table, the only disadvantage is it doesn't give me that, that feeling of the limb length, which I would have on a normal table. Yeah, so that is one thing, that is my reservation for a fracture table. Yeah, so I think we are, the session, if there's any other question? Yeah.
I'm saying without support when they came for the follow-up for the suture removal, but usually we give them a stick for the initial few days. But they don't tend to use it. The reason being that all the muscles which move the hip, they have not been like touched, they've just been retracted and put, so they have less pain. And they're much more confident because the implant, we
so
know
you-
that is a scratch fit.
Yeah,
and it's a press fit
so
stem. So
I think I'll answer that. So with the direct entry approach, the amount of soft tissue, dissection and soft tissue handling is much less as compared to the posterior. So initially the patient doesn't have that much pain. So the initial mobilization is of course better, but I think it's the same after 2 weeks. It doesn't make much of a difference. I don't believe that, it adds anything to that.
The uncemented implant.
No, the implant has to
Is
see
the
now if
approach.
you're doing a typical uncemented hip, I think you can make if your implants are well positioned and well fixed and stable, you can make the patient walk the next day with some sort of a support. It cannot be without a support.
Yeah. That was the. And number two, like, how are you making the offset management with uncemented implant, placing it in varus or kind of that? Somebody just.
No.
You
So
can't do that.
we didn't get it. So in the offset management is not like. So the only thing is that if you're putting your stem in varus, then the offset also changes.
Yes,
Right?
yes.
So you have to be careful. Ideally, it should not be put in varus.
No, but uncemented implant, you can't place it in varus.
It can be if you are undersize your implant, it can go into
Then it will
varus.
become loose later on.
Undersize the implant, so it has 3 points.
In DA, there can be a possibility that you might, if you have not taken the lateral side and the lateral trochanter enough,
Enough, so you can do it.
then it can go into varus.
Can go into varus.
Yes.
Yes, why not? Yeah.
Yes. Sir.
It depends on your confidence. I think if your implant is well fixed, you can make him walk, but with the support, not without support. Not without
So
support.
the answer is preferably give a support, uncemented implant. That's the answer.
I think, thank you for a very interesting session. Thank you very much.
I was with Dr. Ranawat once time and I asked him about the D. He again conceded to it and retraced his remarks that there is a very long learning curve and it has to be in an expertise hand and the spectrum is very narrow. That was the take-home message from him.
I think you're right, but see, how everything goes about is how you are taught in your So if you ask Shubhankar, for him it's very simple because he has seen it in his residency days, right? So